Welcome to the Rational Egoist. I'm your host, Michael Leibowitz. The war on drugs has been wreaking havoc in this country for a very long time. And as such, I take a keen interest in it. And I'd like to have people on who can talk intelligently about it. And today we have such a guest. He's a senior fellow at the Cato Institute and works in the Department of Health Policy Studies. He has also been in private practice as a general surgeon for more than 35 years. Jeffrey A. Singer, welcome to the show.
Good to see you.
So, what are Drug War One and Drug War Two? Because you mentioned that, and I've never heard it quite put that way before.
Yeah, Trevor Burrus and I wrote this white paper for the Cato Institute in 2022, October 2022, called Cops Practicing Medicine. And I'm trying to get that term more popularized because I think that kind of sums it up. We noticed that there were you could almost divide the history of the drug war into two separate wars, Drug War One and Drug War Two. Drug War One was what followed the Harrison Narcotics Act, which was passed in 1914, that at the time was basically a tax act. That's why, unlike alcohol prohibition, it was not initially intended. Well, I'm sure the motivation of the people who passed it, or they like to see people not use a list of these drugs, but they explicitly just passed a law, enacted a law passing a tax on it, so that if you're going to be selling or using, for example, opioids or cocaine and some other drugs, you had to pay a tax, or else you were violating federal law. And the Treasury Department and Treasury agents were supposed to enforce this. When the bill was being debated in Congress, the American Medical Association actually was very concerned about it and expressed misgivings, saying, these are useful drugs that we use every day. And if you're going to make it hard to get them, or you make it illegal, then that's going to be very harmful to patients. So they actually put in there, in writing, that now, by the way, the government didn't mandate any drugs prescription only until 1951. Up until 1951, if you had a drug that was available by prescription only, that was a proprietary decision made by the drug maker. They would say, this is kind of complicated. Somebody's going to mess it up and we'll get sued. Let's specify to the pharmacy, if you're going to sell this, this has to be only by a professional's prescription. That'll cover us. So this was very unusual that in 1914, in the Harrison Narcotics Act, Congress said you can get an opioid or cocaine. They didn't realize that that's not a narcotic, it's a stimulant. It included under narcotics title. You can get that if you have a prescription from a medical professional in the course of their regular practice of medicine. And that kind of satisfied the American Medical Association. They said, okay, as long as we're allowed to prescribe it. So then the law took effect, and Drug War One started off with a series. The Treasury agents suddenly started arresting doctors because they didn't think the doctors were appropriately prescribing these controlled substances. So that was, and again, I guess they're cops, so they would know better. That's why we decided to call it Cops Practicing Medicine. And it was interesting because the medical profession and the public in those days had a much healthier attitude about this. So, for example, there were people who would regularly use morphine. It was actually more common among females, and they would. It was not polite in polite company. It was not. Women didn't want to be seen drinking alcohol, but they can be seen taking their medicine, which gave them the buzz they wanted. And then, like a lot of different kind of drugs, like beta blockers, like antidepressants, like anti-epileptic drugs, opioids, if you take them continuously, you can develop a physical dependency, which is not to be confused with addiction. But if you suddenly stop taking it, you can get withdrawal symptoms. And addiction, on the other hand, is defined as compulsive use despite negative consequences. So that even when you've gone through withdrawal and you're no longer physically needing it,
Right.
you still want it. So anyway, so after the Harrison Narcotics Act was passed, a lot of patients would come to their doctors saying, I've been using this morphine for the last 10 years, a couple times a day. It makes me feel good. And now I can't get it, and I'm getting very sick. And the doctors would say, oh, you know what? You're going through withdrawal because you've been on morphine for so long. So I can give you a prescription for some. So every time you feel those symptoms come out, you could take it. Or, you could just go through it and be miserable for a bunch of days and then get it behind you. What would you prefer me to do? Which was actually very rational, very reasonable.
Sure.
So many, many people said, I prefer you to give me a prescription. I don't want to feel that. So, plus, they were taking at a dose that wasn't interfering with their clarity. It was just preventing them from feeling withdrawal symptoms. So, all of a sudden, the DEA started, I'm not DEA, it was the Treasury Department. Treasury agents started busting doctors. And this was getting a lot of publicity. And the doctors would challenge this, saying, but you said that in the course of practicing medicine, I'm allowed to prescribe these drugs. And the Treasury agents said, yeah, but that's not proper use of the drugs in the course of practicing medicine. Giving somebody an opioid so they don't go withdrawal, that's not medicine. That's not treating an illness.
Can I
Or
ask you a
even
quick
then,
question? I have a question.
sure.
What in the name of God made these people think? I'm talking about the Treasury folks, or government, or the cops, as you call them. What made them think that they were qualified to make these type of decisions? Like, I would never, in my wildest dreams, think that I could tell somebody, "Well, you need to have 75 milligrams of Zoloft, and any more than that's going to be no." Like, I know I can't do that any more than I could fix a car's engine. But these people,
Right.
they get authority and suddenly think that they're in a position to make these
Is that a
decisions.
rhetorical question? Because I got the same question. That's the question we asked.
Well, I thought that there might be some
No, no,
justification, like
they
something
just
might have,
they have these
sparked it.
preconceived notions. They also, in those days, they didn't consider treating addiction as the normal course of medical practice because they thought of addiction as a moral failure, as a vice. They didn't view it the way uh, it's widely viewed by medical scientists today as a compulsive disorder. So that even when doctors say, "Well, this person's addicted," and nowadays, of course, we treat with methadone or buprenorphine. This person's addicted, and I'm trying to help them get through that. That's not a disease. The law says it has to be in the course of normal. That's not normal. We consider normal like if the person just had surgery, he's in a lot of pain, you can give it to him for that, but that's all. And it would go to get challenged. And the courts generally, I don't want to get too much into the weeds. It's in the paper if you want to read about it, but the courts generally sided with the government, the Treasury agents. And eventually, even in times when they thought the Treasury agent, there were some cases where the court said, no, you've gone too far on this one. This doctor shouldn't have been arrested for this. Even in that, by that time, by like the late 1920s, because there were some very famous cases, so many doctors were going to jail. In fact, we found out in our paper that during alcohol prohibition, there were two people going to prison, two doctors going to prison for misprescribing opioids for every one person going to prison for alcohol prohibition related crimes. So, because alcohol prohibition was in effect at that time.
So more
So
doctors than gangsters were going to prison.
exactly, exactly. And people were most of the doctors by the late 20s, they said, forget it. I'm not gonna prescribe this stuff because I can't take a chance.
Yeah.
So they succeed even when there weren't arresting doctors, by the end of the 20s, they intimidated so many that you rarely saw doctors prescribing it for anything other than like post-surgical pain or something like that. And so things kind of quieted down. Of course, that fed the black market. So you had a very healthy black market in, at first it was morphine. This is interesting. A lot of people don't know this, but heroin is just the brand name that Bayer chemical company of Germany gave to diacetylmorphine or diamorphine. That's a generic name for it. In the 1890s, it was available as a syrup. A lot of people gave it as a cough suppressant or to help you fall asleep. They gave it to kids. As people were being arrested for possessing these now prohibited opioids unless you paid the tax. So the the head of the Bureau of Narcotics at that time became persuaded that diacetylmorphine caused moral corruption. It decayed your morals. And he asked Congress to ban it. And again, the medical profession, medical association testified saying that that's crazy. That makes no scientific sense. And we only have a handful of pain medicines in that day and age. Codeine, morphine, heroin. That was about it. Please don't ban it. We need this. Congress banned it. It was called the Heroin Act in 1924. Most of the other developed world never banned it. So a lot of people think that this is like an evil drug. For just kind of pharmacological perspective, it's about the same potency as oxycodone. It's half the potency of Dilaudid. The generic name is hydromorphone, which is completely legal. A lot of people have received it as a prescription. In much of the developed world, they just stopped calling it by the brand name heroin, and they call it diamorphine. And in Canada, the UK, Europe, Switzerland, the works. Sometimes, rarely, doctors would prescribe it for pain management because there's so many other drugs now that are better, and heroin is kind of short acting. But it's used particularly since the 90s in about a half dozen countries, including our neighbor to North, Canada, in the same way that methadone is used. Because there are some people that methadone or buprenorphine isn't working for them to treat
Hold on
opioid
one
use
second.
disorder.
Buprenorphine, that's commonly known as Suboxone. Is it the same thing?
Yeah, well, yeah, the brand name for buprenorphine was Subutex. Sub because you take it sublingually, you put it under your tongue,
Okay.
it dissolves. Then they mixed it with naloxone, the opioid overdose antidote. It works by binding with the opioid receptor, displacing the opioid that's bound to it, but not making the receptor work. It just okay. So they mixed the two together in a pill form to prevent misuse of the drug by people who are prescribed it. So this way, if you take it orally, the naloxone doesn't get absorbed. Doesn't get absorbed through the intestinal tract. Just the buprenorphine does. But if you want to dissolve it and liquefy it and inject it to get high, the naloxone works intravenously and will block the effect of the. That's why. Okay, and they gave the brand name Suboxone, which is mixing Subutex with naloxone. But
Oh,
we
okay.
medically we just call it buprenorphine because we know what we're talking about. The most research shows either methadone or buprenorphine are the most effective ways of treating opioid use disorder. You could, depending on which study you read, some people say buprenorphine is better, some people say methadone's better. Probably they're both, you kind of got to pick the patient. Some patients, one works better for, some works another. The disadvantage of buprenorphine is that it's a partial opioid agonist, which means it activates the receptor, but not fully. It's a class 3 controlled substance. It was originally invented as a painkiller because it's a partial opioid agonist. It's less likely to suppress your respirations if you take too much. The downside is it doesn't give you much of a high because it's a partial opioid agonist, unlike methadone, which is the same potency as heroin, but it's a full agonist, and it's just long acting. So you take your methadone that can last through most of the day, and at the dose you're taking it, particularly orally, it not only will prevent you from going into withdrawal, but it's not enough to make you cognitively impaired at that dose, especially since you've been using high doses of, let's say, heroin for a while. And because it's a full agonist, it does reduce the craving that you have for it. So, like I say, it depends on on the patient, but there are some patients for whom both of those don't work. And starting in the early 90s, researchers in Switzerland found that you can give them heroin, and you can actually give them a clean syringe, and you don't give them the pharmaceutical grade diamorphine, and they can inject it in. And for some people, and there've been a lot of studies saying for some people that does the trick. They inject enough again to prevent withdrawal symptoms and prevent craving. Then they're able to get a job and go to work and get their life straightened out. And the whole idea behind medication-assisted treatment for addiction is basically to help you stabilize your life, because usually you got all of a sudden you have a whole lot of time on your hands because you've been spending your whole day either trying to raise money or meet your dealer. And now that's you don't have to do any of that stuff. So now you can kind of get a job, reestablish relationships, get a place to live, and eventually those are the kind of things that help you overcome addiction. In fact, research shows that a significant number of people on their own, without any treatment, by the time you hit their 30s or so, just outgrow it, which argues for it being a behavioral disorder like ADHD, which people can outgrow. Anyway, we're getting off on a tangent. So in drug war one was was what I was just talking about. But by banning heroin in 1924, by the end of the 20s, heroin became the most common drug sold on the black market. It eclipsed morphine, which had been the most common drug sold on the black market. And an economist would have predicted that, because if you're going to sell something in the black market, would you rather sell something that's totally banned, there's no other way to get it? Or would you rather sell something that there are other ways people can get it? Like robbing a store or faking pain and getting a prescription. So it was just more, maybe a better business sense. And that's that's the heroin, banning heroin is what created the heroin addiction problem in the United States. Everything seems counterintuitive, but that's the way you go. Whatever you do, whatever the government does, the opposite is the result. So then came drug war two, which is, we kind of time it with this century. Even nobody really noticed, but researchers at the University of Pittsburgh School of Public Health were able to get data from the CDC going back as far as the 70s. And it was a difficult project because the CDC was changing its terminology for data in different periods of time. So you had to try to figure out, like, or am I comparing apples to apples? So it took a while, but they were able to do it. And they found that the overdose rate from non-medical drug use has been exponentially growing since at least the 70s, and shows no end in sight. The only thing that's changed at different periods of time, different drugs are in vogue. So, for example, in the late 70s, early 80s, heroin was the major cause. A lot of soldiers were coming back from Vietnam with heroin habits. Then cocaine. Then in the 90s, it was Vicodin, hydrocodone, and Percocet. Then by the end of the 90s, early 2000s, it was oxycodone and OxyContin. By the way, this is non-medical use, so people were recreationally using it. And then now, of course, it's fentanyl, and soon it's going to be nitazines, which we could talk about later if you want to. But the point is that this is not something that suddenly appeared, but it finally caught the attention of the press and lawmakers around 2002, 2004, because now it was hitting such a high number that it was attracting people's notice. Not only that, in the 80s and 70s and 80s and early 90s, a lot of the overdoses were involving people living in the inner cities and minority communities. But now these overdoses are involving like upper middle class white people living in the suburbs. And now we got a crisis. So they had to step into action. So they decided it's those doctors who are prescribing opioids too much. And there were some, there's no question, which helped feed the narrative. There were doctors who, a doctor was arrested and convicted in Newport Beach, California. Word got out that he would show up at the Starbucks every Tuesday morning at a certain time, and for $600 a pop, he'd write you a script for OxyContin.
Yeah, the thing that's nothing new. I remember when I was a little kid, my parents were both drug addicts, and they used to do what was then called doctor shopping. They would run around town to town, and it soon became known who the doctors were that would prescribe you what you wanted. So
Yeah.
that's not like, it's not a new phenomenon.
Right. And there were some who were like in Florida, there's a thing they call the Oxy Express, where dealers would fly people down from New York on their dime and tell them, go to this pain clinic and say these things, and that doctor will give you a prescription for 500 OxyContin. Then go to this pharmacy, but make sure that this particular pharmacist is on duty. You want him to get the prescription, he'll fill it, and then come to me and I'll pay you. So I would argue, well, it's not like nobody wants to blame prohibition. So the policymakers and the press are saying, see, those doctors are creating a population of zombie-like drug addicts. No, these were non-medical users, and there were some doctors, pharmacists, etc., who realized because of prohibition made, I'm working an hour to get $200 for seeing a patient for their, abdominal aches and pains, or I could write a dozen scripts at $600 a pop because it's on the black market. So people will pay that kind of money for those scripts.
Sure.
So it brings out the worst in people. Prohibition is very corrupting. It corrupts doctors, pharmacists, cops, prosecutors,
Sure.
politicians, during alcohol prohibition. I mean, all of the Chicago's entire government was owned by Al Capone, right? But they don't want to think about that. They want to say, see, it's those doctors writing the scripts. We did studies. It was published in the Journal of Pain Research, looking at CDC data and data from the National Institute on Drug Abuse, showing that they started taking this survey, National Survey on Drug Use and Health, starting in 2002, and every single year, past months non-medical use of prescription pain relievers by adults aged 12 and up, and past year diagnosed with prescription pain reliever use disorder, that's the terminology that they used, was basically unchanged. And it was I forget now the percentage, but it was a very low, like 1% or so. Never changed. And during that period, between 2002 and 2014, the prescriptions written per 100 population first doubled, peaked in 2012, and then came down. So there's no correlation between people who are non-medically using and prescriptions being written. Clearly, the more prescriptions you write, the more prescription pain pills become available to get what they call diverted into the black market, where non-medical users can access them. And again, the survey found that on average, 25% of people who said they use prescription pain pills recreationally said they never went to a doctor at all. I mean, 25% went to a doctor. 75% said they never went to a doctor at all. They either got it from a friend, a dealer, or a relative. So the narrative is that we created this population of drug addicts, but that doesn't make sense. Also, and you'll see this in the Cops Practicing Medicine paper. The National Institute of Drug Abuse takes also a survey on the addiction rate, and it breaks it down by substance. And for adults aged 18 and up, the percentage of adults aged 18 and up addicted to prescription pain relievers since they started doing the survey in 2002 has never been higher than 0.7%. It's basically been just a level line ever since they've been taking the survey. So, you put two and two together and you figure out that there's a growing population of people who want to use drugs non-medically. There are people who need the medication. Some doctors might be prescribing too liberally, but they're not creating quote unquote drug addicts out of patients. They sometimes, and there's a lot of logical reasons for this. For example, me as a surgeon, if I thought my patient might run out of the prescription, and under federal law, you can't just call in a refill for a controlled substance. You have to have the patient seen in person, which is very, you got a person's in a lot of pain from their surgery.
Sure.
And they got to get driven down to see you so you could write the darn prescription that you knew you're going to write anyway, but you have to be able to document that you saw them. So, and if it's on a weekend, they go to the emergency room, which is poor utilization, obviously, and costs money. So what we oftentimes do is we try to kind of guess correctly, say, well, I don't want this guy to run out over the weekend and go to the emergency room. So let me give him 50 oxycodones, and then they'll come see you in the office sometime frequently and say, you gave me 50. I have like 15 left over. What should I do with them? Of course, now I'm supposed to say, according to the government, turn them in to your local Walgreens or CVS so they could destroy them. But what I'm telling them now is hold on to them, because someday you may be in pain and nobody's going to prescribe anything for you, and that's going to be your lifesaver. That's what I tell them.
Yeah.
Okay. And I'm telling that I'm putting them first. So anyway, then as the government decided that it's the doctors, they started clamping down on doctors. You had SWAT teams. We have all sorts of stories in the news. First, there were these actual pill mills and doctors who were drug dealing. But again, don't blame don't blame the opioid, blame the prohibition, because
Right.
that's why they were doing it.
Sure. People respond to incentives. That's just the
Yeah.
way life works.
Right. And so you're creating the incentives with your prohibition. So, but they that those very, obvious examples, which are on the news, got a lot of attention, just fueled the narrative. You see, the doctors are hooking everybody. So now opioid prescriptions rates is at the level that it was in 2000. It's come down precipitously. It peaked in 2012. And you can almost see as it peaked, if you chart heroin overdose deaths and then later fentanyl overdose deaths, you can see them go up as prescription pain pills went down. And again, you don't have to be a genius to figure this out. People were trying to get a hold of oxycodone or hydrocodone on the black market. It was the source was drying up, so they bought heroin. And then later on, we call it what we people in policy world call the iron law of prohibition. The harder the enforcement, the harder the drug. So law enforcement enforcing prohibition incentivizes uh, drug trafficking organizations to come up with more potent forms of whatever it is they're trying to smuggle, so they can smuggle it in. It's easier to smuggle. It's smaller. They could, when they take all of the risk that they have to take, the increased risk, they could subdivide it into more units to sell, so it makes it more worthwhile. Just why during alcohol prohibition, they weren't smuggling in beer and wine, they were smuggling in whiskey. So that's how fentanyl came to replace heroin, and it was also accelerated by the COVID-19 pandemic because with border closures, it was hard to ship opium from which you process heroin, and also the acetic anhydride that's used to make heroin out of opium. There was a supply chain problem with that, but it's easy to just make fentanyl in a lab like you could make meth in a lab. And so they just kind of switched out to that. But now they've been adding the veterinary tranquilizer xylazine to it, or the users call it tranq, which makes it more potent. And then in the last few years now, there's a new totally synthetic opioid that's appeared on the scene called nitazines. And that's a derivative of a chemical called benzimidazole. And benzimidazoles are used to make so many things from Prilosec, which people take for an acid, to antifungal agents, to blood pressure pills like losartan. They're all benzimidazole derivatives. So if law enforcement wants to crack down on the shipment of the precursors to make nitazine, that's going to be really hard to do because these precursors are used to make dozens and dozens of everyday drugs that we use a lot and value. They're also trying to they're blaming this on China too, because that's another good thing. Everybody hates China. So they're
That's a
saying the
nice talking
Chinese are
point,
selling the
right?
precursors to the Mexicans to make the fentanyl, but they don't tell you that so are the Indians. So if we crack down somehow and get the Chinese government to stop the labs from making the fentanyl precursors and shipping it to Mexico, the Indians are going to love that because that's great for their business. And then if
Sure.
we crack down in India, it'll move to Malaysia or Myanmar. But even more than that, what people don't understand is you can make precursors of precursors. And that's even going to be harder. How do you know what that's going towards? And also, they're not Mexican cartels anymore. They're transnational cartels. You hear about all the violence going on in Ecuador. That's because they're in Ecuador now, teaming up with the Albanian cartels, which sell most of the drugs in Europe. This is like our prohibition has created these big multinational syndicates
Right.
and we're making them stronger and stronger and wealthier, and we're destabilizing all these governments, and and we still won't learn.
Now, during alcohol prohibition, alcohol related deaths went up and poisons and whatnot went up. And like you just said, when they crack down on prescribing, overdoses go up. Now, I've been enmeshed in the drug culture, since before I can remember, really. So I understand why. But I'm guessing there's people out there that don't understand. Well, okay, if you're outlawing this, why is it leading to more deaths? Now, to me, when you have to go, and I'm going on, when I used to use drugs, I'm going to meet some guy I don't know, and I'm going to buy a package of heroin, a powder from him, and I'm going to go use it. Now, he probably also did a similar thing where he went and bought a larger package from somebody he didn't know, doesn't know what's in it. So you end up with this, and there's an incentive on one hand to make it more potent, like you said, but also to mix it with things to make it a larger quantity than it otherwise is. And there's no way for the addict, or the pain
You even have to be an
management
addict, just
user.
be a user. Yeah.
Yeah, it could be a user or a casual drinker in the, the 20s. You're going to buy this stuff, and these people are trying to maximize profit. They're mixing it with who knows what, and you have no way to
Benzene
know
in it
what's in it.
during alcohol prohibition, getting mixed with benzene, with methyl alcohol or wood alcohol, which can make you blind. Yeah. Yeah.
Now, why is it so? It seems it's so, like you said, it's obvious. It's so commonsensical that this is what would happen. Like, people don't go to McDonald's, for instance, and get poisoned. Usually, I guess suppose someone could pull a rabbit out of the hat and say, "Look, it did happen here." But and people don't go to their local package store and end up drinking benzene. So why
In
don't
fact,
people
that's what I say.
understand? Yeah, why don't people get it? And your common person, I guess I can understand, but policymakers should know this.
You know what? I think they do. Okay. I think, well, there's a certain amount of moralizing going on. You think it's bad. Drugs are bad. Okay. Just like the Mr. Mackey on South Park. Drugs are bad.
Drugs are bad.
Yeah. And so there's a certain amount of moralizing like that, but there's also cowardice. I think it's been so inculcated into the culture, going from President Nixon's war on drugs in 1970, uh, and starting in, the Harrison Narcotics Act itself, when it was passed in 1914, was fueled by the same people who were behind alcohol prohibition. And many people might not know, but they also advocated tobacco prohibition. And about 20 states had a ban on tobacco, which fueled a huge black market in cigarettes. So, and the states gave up on that in the end of the 20s. But there's a group of people who basically want to tell you what they think is best for you to do, and then try to impose their morals and their lifestyle decisions on other people. And so that's part of it too. But there's a lot of cowardice involved, and as well as, like I say, a prejudice against certain drugs. Like, for example, if you put things in proper perspective, alcohol is a whole lot more dangerous than opium.
By
What
far.
makes
Yeah.
opium dangerous is the black market.
Yeah.
It's when you thought you bought oxycodone and it was fentanyl and you didn't
Yeah.
know it and you overdosed.
You know,
But
when I was 16 years old, I had a biology book in school, and they had comparisons of different drugs. And I remember looking at the effects of alcohol on the human body compared to the effects of heroin on the human body.
right.
And alcohol is far worse. Like, I mean, it's not even close. Affects, and I don't want to say destroys, but it harms virtually every organ in the body.
Virtually every organ. Yeah. Your
Yeah,
liver, of course, your brain, your heart, your pancreas, causes cancer of the stomach and
right.
esophagus. Yeah, opium's derivatives in general, of course, you could overdose. You could overdose on you could overdose on aspirin. You could overdose on water. I don't
Sure.
know if you know that.
Especially when you don't know what's in it. You don't know
Yeah,
the
yeah.
milligrams you've taken.
But if you know what's in it, long-term use can cause constipation. Okay, that's not fun, but it's not liver disease, and you can deal with it. And there is some evidence that it might, over a long period of time, reduce some of your gonadal hormones like estrogen, testosterone, which could cause osteoporosis. But again, that's correctable. You're not talking about killing your liver, your heart, or giving yourself cancer. And so, yeah, it's much safer. What makes it dangerous is that you had to get in a black market. Even if you inject, it's because you injected with a dirty syringe and you shared with somebody else, and you're spreading around HIV and hepatitis. If it was clean, you wouldn't be doing that. But so anyway, that's the two drug wars to answer your question.
Now, you also talk about that when cops are making medical decisions, how it creates an antagonistic relationship between doctor and patient, right?
Yeah, it's
So
gotten really bad lately.
can you talk about that a little bit?
Yeah, in fact, I wrote a blog post about this about a week ago. A professor of anesthesia and pain medicine at the Vanderbilt Medical School uh, wrote an op-ed in the New York Times, and I linked to it in my blog post, where she was very, very upset that people can't even when you prescribe an opioid for pain for a person who needs it, including a terminal cancer patient, you're going around to pharmacies now, and you can't get it because the DEA has quotas, and they just don't have it. It's on back order. So even when the doctor's not afraid to prescribe, and they know that no cop is going to challenge me on this one. This guy's got terminal cancer. I want to give him some oxycodone to help him deal with his cancer pain. Then they go to pharmacy and they can't get it because there's none there. Because for the last several years, the DEA get this, the DEA sets production quotas for every single controlled substance, not just opioids, Adderall. You probably heard about an Adderall shortage. So they're supposed to have the knowledge of just how much of each type, oral, injectable, all sorts, each type, each chemical type of every single controlled substance that all 330 million Americans will need next year. Okay. And then they tell the different manufacturers, you are allowed to make this many, you are allowed to make that many. And then if a plant has to temporarily shut down because they got some quality control issue or something like that, we got a shortage because the other plant isn't allowed to pick up their production to make up for the fact that the other company's plant had to shut down because they were put on a cap, only a certain amount. So we're creating all these shortages that's affecting patients who are being prescribed pain medicine for things that even the cops would approve of. Okay. So that's a big problem. But in addition to that, people who have been having their chronic pain controlled for a long time on a steady dose of opioids has allowed them to enjoy their life and have work and have a productive life. Even if they still have some mild pain, it's bearable. Suddenly they're being abruptly tapered, or doctors are saying, I'm not prescribing you anymore because they're afraid. They're afraid they're going to get arrested.
Right.
So it's creating that kind of problem. And a lot of people are either getting suicidal or they're going to the black market to get their pain medicine, which turns out to be a cause of overdoses because it's not what they thought it was. So that's the antagonistic relationship. And now the author of that article, Dr. I think you pronounce her name, Durbacula, Shivani Durbacula, she bemoaned this, and then she said, we need to get the DEA out of practicing medicine. And I'm saying, okay, that's another way of saying we need to get cops out of practicing medicine. I like that. And then what were her suggestions? We should have the CDC and the FDA be regulating all this. And I'm thinking, no, you're just replacing. First of all, if you don't listen to the CDC and FDA, guess what happens? They call the cops.
Yeah.
But besides that, we don't need to have government agencies, particularly those like the CDC and FDA, which are subject to all sorts of political pressures and groupthink, and to impose one size fits all, regulations on the way doctors practice medicine. We should get the government out of this altogether. In our white paper, we have some suggestions. For example, in 2016, the CDC, in reaction, they totally bought into the narrative that doctors are creating this population of drug addicts. So they published pain management guidelines, which they admitted were based on mostly type 4 evidence, which is the weakest of evidence and could be subject to change. And if we learned anything during the pandemic, we know that a lot of stuff was weak evidence subject to change. So, and they made certain recommendations that were immediately controversial among academic pharmacologists and pain specialists. But and they said, these are just recommendations. You don't have to follow them. We're just kind of giving you like a rule of thumb. But of course, when a government agency just makes a recommendation, that's like when Tony Soprano recommends that you do something. Okay. Generally speaking, you don't want to piss off Tony Soprano. So almost every state, 38 states, took those recommendations and put them into law. So you have politicians, many of whom have not even a remote knowledge of medicine, passing a law saying, in my state, you can't prescribe more than 5 days worth of pain pills to a person after surgery. Oh, really? I hope I operate on you and you need 10 days worth. So, and these become law. Eventually, so many organizations, including AMA, criticized the 2016 guidelines that at the end of 2022, just a little over a year and a half ago, the CDC revised them. And they actually said a lot of the stuff we told you before was inaccurate, okay? But that doesn't matter because here in Arizona and the other 38 states, we're trapped in the year 2016 because the 2016 guidelines were put into statute. Thank goodness they didn't put into statute what dose of insulin I should give for a diabetic or what dose of losartan I should give for high blood pressure, because every time we know more or there's a certain situation, we have to call a special session of the legislature to get them to revise it. So recommendation number one is states should get out of it, putting into code any sort of recommendations made by any specialty organization, because these are academic organizations having discussions based upon what we know about the data at this particular point in time, which could be different 2 days from now. We learned that during the pandemic. So don't put this in statute. That's number one. And if you have a statute, repeal it. Number two, the right now, the DEA just anytime they want to, every state has these prescription drug databases where it keeps track of all the prescriptions that every doctor has written, every patient has filled at a pharmacy. And they just every once in a while go on these fishing expeditions through these prescription drug databases. And that's why doctors are intimidated. They figure, I just wrote a refill. I hope they don't think that I did something wrong, because I know they're watching me. So you should require that before any law enforcement can go through that prescription drug database, they need to get a warrant showing there's probable cause that a crime is being committed, a crime, not a difference of opinion on how to practice medicine, but an actual crime, like a guy's dealing drugs. And they're not hard to get, these warrants. Now, many states, including my state of Arizona, have passed these laws, but the DEA has ignored them because they say that doesn't apply to the federal government. And it's been taken to federal court on occasion, and the DEA has prevailed. It's the supremacy clause of the Constitution. So Congress needs to say federal law enforcement can't go through a prescription drug database without a warrant. Then, if they go through the prescription drug database, and in the process of doing so, and this happens a lot, they say, wow, that guy's prescribing an awful lot of oxycodone. That sounds inappropriate to me. Okay. Well, then it should be placed in law that if you think it's inappropriate, we have mechanisms in place for that. They're called licensing boards. Now, I personally don't like licensing boards. I don't think we need them in a free society, but we have them, and their job is to review inappropriate medical practice. That's who patients are supposed to complain to if they think they were mistreated. And they have a due process system, because what happens is if a patient or a law enforcement officer says to the licensing board, we think Dr. So-and-so is over-prescribing a medication in inappropriate situations, the license board then has a bunch of doctors in their, who they consult, part of their, who practice in their state and in that specialty, and ask them to review the case as doctors and give the licensing board an opinion as to whether or not they think this might be kind of, an outlier outside this, what they call the standard of care. And if so, then they invite the doctor down, and he's got due process. Doctor's got a chance to explain himself. And more often than not, after explaining himself, the doctors who are reviewing the case say, all right, I could see that. That's the way it should be handled. This is a debate among healthcare practitioners about what's the best way to treat a certain situation. And most things in healthcare are nuanced, and they're not black and white, and every individual is different, even surgical things. There are 4 or 5 different operations for one problem, and the different ways you can do it all depends on the situation. So if you, cop, think that a Dr. Jones is practicing inappropriately, well, then let the licensing board know and they'll look into it. But you can't do anything about it. This is not in your domain. You just make sure he's not dealing drugs on the street and stuff like that. That's all you're supposed to be concerned with. And those are some reforms you could do. Unfortunately, Dr. Decriminalization didn't recommend them. She just recommended that we replace the DEA with the CDC and the FDA. And it's just a different set of
the recommendations that you're talking about. I understand they're very practical. And if you're trying to advise on policy, given the current context and culture, that's kind of, what you're going to do. My personal recommendation would be legalize all drugs, get the government the hell out of the business, and respect the rights of people to use whatever the hell they want. Right?
Totally agree with you 100%.
Right.
But I'm just saying we're dealing with
yeah. So, but the prohibitionists think that they now have a silver bullet argument, many of them anyways, in what occurred recently in Oregon with the decriminalization and now the recriminalization. To me, this is silliness. And I'll tell you why with decriminalization. Just one argument. I once had a debate discussion with a good friend of mine who was an African-American activist. And he said he wasn't for full legalization. He said what they should do is legalize use, but keep sales illegal. And I told him, okay, well, let me just point out a scenario to you that's going to occur. You're going to have a situation where a car full of white kids pulls up into a black neighborhood to buy drugs. The cops are going to come. The five white kids who were there to use are going to be set free, and the black guy who's selling the drugs is going to be arrested. What type of optics do you think that is going to create when you have white kids going free and all the black kids there are getting arrested? And he said, wow, I didn't think about that. Now, that's just one example. When you try to half-ass things,
Well, it's not
you're
just
going to
that.
end
I
up
mean,
with
but
problems.
that's a point. But even during alcohol prohibition, most people don't know this. They weren't arresting people for drinking.
No, it
They
was
were
the
arresting
dealers.
the dealers and the
Right,
bartenders. Yeah. So that was kind of decriminalization in a certain respect.
right.
So decriminalization. Well, first of all, Oregon became in I'll back up. In 2001, Portugal had the highest drug overdose rate and heroin addiction rate per capita in the European Union. And they said, you know what, this isn't working. Let's try something different. So they decriminalized drugs and they made harm reduction programs much more available, including, rehab programs and the like. And within a couple of years, teenage heroin use became the lowest in Europe. 75% of heroin users were no longer addicted. And they still, to this day, have the lowest per capita overdose rate in the EU. Okay. Even though drug use has gone up there, like it's gone up all around the world in the aftermath of the COVID pandemic. I think that had a lot to do with it. Meanwhile, Oregon decided to take a page out of their book. And in November of 2020, voters passed Measure 110, which decriminalized all drug possession in Oregon. Now, it didn't take effect until February 2021. Guess what else was going on in February 2021? The
COVID.
pandemic and lockdowns, okay?
Right.
The idea behind Measure 110 was that at the same time, all the money saved by not putting people in jail is going to go towards expanding access to drug treatment and harm reduction programs, okay? And I'm not making an argument that taxpayers should fund those things. I think the government should get out of the way because there are plenty of private organizations that would like to do this.
Sure.
But nevertheless, that was their plan, okay? But for the first year, of course, everything was locked down, including methadone clinics. So forget it. And of course, there was a whole lot of despair. Now, there was research done in February, reported in February, showing that by the time of the beginning of this year, there were only about 4 months when all of these intended harm reduction programs were up and running, operational. 4 months. Okay. Now, meanwhile, during that stretch between the beginning of 2021 and the end of 2023, overdose deaths went up dramatically. And they're blaming that on decriminalization. But like you mentioned, decriminalization doesn't mean that all of a sudden when I buy a drug on the black market, it's safe. No, it's the same unsafe drug. And the evidence shows it didn't lead to any greater number of people using illicit drugs. It just meant they weren't being put in a cage for it. But the other thing that a lot of people are not aware of is that fentanyl, different drugs hit our country in different waves. So when fentanyl first started showing up on the scene in the United States around 2012, it was mainly confined to the Northeast and New England. And it gradually worked its way across the country. I think by 2018, fentanyl overdoses predominated in 28 states east of the Mississippi. It made its way to the Pacific Northwest around 2020. Okay. And of course, every place that fentanyl hit, overdoses soared because it's so much more potent than heroin or oxycodone. So, and in every state when fentanyl hit, the spike was almost identical in overdose deaths. So in 2021, when Measure 110 went into effect, fentanyl appeared on the streets and everything was on lockdown. Okay. But if you look at the overdose spike in Oregon from 2020 to today, it's the same spike as it was in the state of Washington and in Northern California because it hit those areas at the same time. So the people who are drug warriors immediately interpreted this spike as, you see, we decriminalized drugs. Look how overdoses went up. We got to go back to recriminalizing. Makes no sense. It has no connection to decriminalization at all. And now what they say, oh no, we're going to be very careful. Or we're going to say, if you don't want to go to jail, then you go to rehab. Evidence shows that forced compulsory rehab actually not only does it not work, you know, the old joke, how many psychiatrists does it take to change the light bulb? Only one, but the light bulb's got to really want to change. Same kind of thing. So, the thing is that compulsory therapy doesn't usually work, but on top of that, it actually may increase overdose deaths because if you were forcibly kind of tapered off and you lost all your drug tolerance, your so-called detoxed, and now it didn't work, so you go back to using, and you tend to use the drug that the dose that you used to use because that's what you remember gave you the effect you wanted, and you're more prone to overdose because you lost your tolerance. So that's what the evidence is. In addition, just think about this. Let's say you're just a recreational, you know, the data show 80 to 90% of people who recreationally use illicit substances who start using as adults, like over the age of 25, when your frontal cortex is fully developed, 80 to 90% never get addicted. Professor Carl Hart at Columbia wrote a book about this recently called Drug Use for Grownups, which is very revealing. You know, there are people who use heroin or cocaine on weekends, and you don't become addicted, and they like using it. So let's say you're caught possessing a drug that you don't have a compulsive disorder. You just like to use once in a while. Well, now you got to go to rehab, right? But you don't need rehab because you're not addicted. You were just using it. But so there's a whole lot of, but the main thing is they, with only 4 months of harm reduction programs in existence, and with the lockdowns from the pandemic in effect, and the fentanyl wave hitting at that time, they immediately panicked and used that as an excuse to go back to the old way. And we know how well the old way's been working. So it's very disappointing. And what I worry about is in other states that were thinking of following Oregon's lead, especially with the press attention, you know, you see these headlines, Oregon decriminalized drugs, and they realize they made a mistake. So this going to, even politicians who want to do it are going to be intimidated into backing off.
Yes.
So that's a real problem. And the same thing we're seeing now, Idaho recently and a couple of just repealed their law that allowed needle exchange programs to exist, syringe services programs. Well, believe it or not, I mean, that's the kind of thing that's non-controversial. Every single public health organization, President Trump's Surgeon General Jerome Adams went around the country telling states legalize syringe services programs. That's what they're called. And in fact, he had an op-ed in the USA Today just the other day on that. And so in Idaho, lawmakers said, you know, we legalized needle exchange programs in 2017, and the overdose rate's still going up. Didn't work. And I'm thinking, what made you think legalizing, giving out clean needles is going to reduce overdose deaths? It's going to reduce HIV and hepatitis.
Yeah.
And there may be a little bonus because in recent years, they've been also handing out naloxone along with the clean needles, and maybe that'll prevent a couple of overdose deaths, but that's not their purpose. Their purpose is to reduce HIV and hepatitis and all sorts of bloodborne diseases. So what were you thinking? You thought
I've lost you. Okay, you're back. I lost you for a second.
Oh, okay. I'm sorry. Where did you lose me?
It's hard to say. It was only a second, and by the time I started saying I've lost you, you were back. So I think we got the
yeah. I'm
gist
saying
of
as long as you have a black market, you're going to have overdose deaths. But you may not get HIV or hepatitis if at least people could use clean syringes.
exactly.
So,
Well, thank you so much for being here today. Tell people where they can find you, where they can find your blog.
okay. Well, I can be found at the Cato Institute website, which is cato.org. I blog regularly on the Cato at Liberty blog, which is posted at the website, or you could just, you know, Google Cato-at-liberty.org, and that'll give you the blog. Plus, I write a lot of articles and papers, and they're all available on my bio page, which is available at the Cato website.
Excellent. Thank you so much again.
Yeah.
For now, this is the Rational Egoist signing out. I'm Michael Leibowitz. Remember, press the little like button. It really helps. Share the episode. That helps as well. And if you leave your comments, it even helps more. Thanks a lot. Till next time.